Hi all, here I am again. Oops, I'm wobbling with my phone, sorry about that. Yeah, it's Ian here, Keith, whatever. Right, last time I got up to the point of taking my own advice. But I need to lay one thing out before that. What happened in, when was it now? 2006, something like that. I basically had, and some people know what this is, it's called AF, which is atrial fibrillation, which is where your heart starts to go into funny rhythms. And one of the ways that they sort it out is if it doesn't revert automatically, is that they put you into what they call a cardioversion, where they put you to sleep, general anaesthetic, and then use a defibrillator, and it shocks your heart back into normal rhythm. Now, when they do that, there's all sorts of risks and potential side effects. One of the risks is that you could have a stroke, you can have a heart attack, obviously it can do damage to your heart. And with AF, they say that you don't die from AF, you die from the side effects of AF, which is mainly a stroke. Even when they're not doing the cardioversion, you can have a stroke because your blood flow isn't right. So they put you on blood thinners and tablets. I think they're called alpha blockers or beta blockers, I can't remember which slows your heart right down and helps basically stop the AF attacks, atrial fibrillation. Now, over the course of the next 15 years, something like that, I've had 9 cardioversions in hospital, both in Spain and in the UK. Now, what that does is that it makes you consider your life and consider your morbidity or, death. So you basically sort it all out in your brain and basically, understand the risks and understand that, we've all got to die at some point. The other thing that it strangely does is that, and oh, by the way, it's hereditary. So I got it from my dad, my brother's got it. What was I going to say? Yeah, it's progressive. So it never improves, it gets worse, and will keep getting worse until basically it kills you. So what I noticed was that in the early days I was having a major AF attack probably every 18 months and going into hospital and have cardioversion, and then that reduced down to every 12 months and then every 9 months and every 6 months. They'd change your meds a bit and then it'd go back a bit and then you'd start climbing down the scale again. So I got to a point about 5 years ago. It was during COVID, where I spoke to the cardiologist, couldn't think of the word, and basically he changed the meds and it worked bloody wonders. It put me on what's called flecainide, and to my family I've told them all this so they know the story, and basically it sorted me out. I still occasionally get AF attacks, but they'll only last an hour, maybe 2 hours, and then it auto-reverts, goes back to normal. But the thing that relates to your prostate is that when you're in AF, when your heart's doing its thing, you know about it. But one of the things it does is it your brain produces a hormone that makes your kidneys go into overdrive and start producing masses of urine. So as a consequence, and of course, if you've got prostate problems where you're not emptying your bladder properly, you haven't got much capacity to carry that. So in effect, when I go into AF, if it's night time, which it usually is, and I'm in bed, I get up, go to the toilet, pee, everything, go back to bed, lay in bed sometimes just for a couple of minutes, sometimes for 5 or 10 minutes, and I'm back up again to the toilet, peeing again. So literally for 2 hours while you're in AF, you just can't sleep because you're forever peeing. But obviously prostate problems don't help that. But of course it conditions your brain and your mind into coming to terms with death. Because obviously you live in the risk every day, and I've been doing that now for 15 years, something like that. And my brother's now suffering the same thing, which I'm sure he'll be watching this and he'll be nodding and understanding everything I'm saying. And I'm sure a lot of other people who are watching this have gone through similar things and will be nodding as well. So it was... now with having AF, what the GPs do is that they monitor you. And the way that they monitor you is when you're 50 anyway, they put you on to like an MOT. And they'll get you in, they'll check your blood pressure, and they do all the usual sort of routine things, check your urine, listen to your heart, check your heart rate, oxygens, all the rest, all the usual easy things. And part of that is that they do a blood test to see how your meds are doing and whatever. And they do that every year on your birthday, or at or about your birthday, which for me it's April. So I think it was at or about one of these visits, and this was 2018. I mentioned to the doctor and said, look, I'm having trouble urinating. I'm finding I'm getting up 3, 4, 5 times a night to urinate. I'm getting urgency to go, and when I go, I'm hardly doing anything. So he says, oh, okay, fine. Now, this is where it starts to get technical now. DRE, and I'm sure some of you will know exactly what I'm saying. And the other thing is PSA. Now, to those of you that don't know, DRE is digital rectal examination. And it's not like digital your phone or your computer. It's digital your finger. That's your digit. Rectal examination. Put the two together and you'll come up with a solution. Your prostate sits right against your intestine, just inside your rectum. So what they do is that they put rubber gloves on, plenty of jelly, lubricant, and they go in there and they feel your prostate with a finger. And what they do is they're looking for rough or lumpy surface. So if it's nice and smooth and round and, uniform, they don't worry too much. So in 2018, I basically said to the doc, I've got this problem, urinating. So he says, okay, we've got to do a DRE. Or I have to do a DRE. And he's a big hunky male, so I thought, oh, bloody hell, this is going to hurt. But he actually said, my learned assistant will do it. And it was a nice young girl, so I was quite pleased. Well, not pleased as such, but I was relieved. So anyway, and I'm sure you've seen it or whatever, or you've had it done, But effectively, you've got to lay on your side, put your knees as high up as you can towards your chest, Obviously I have no pants or underwear on. And that exposes your rectum, and then they're very discreet, very good at it, very quick. You can hear the rubber gloves clicking on and then the gel. And they're just going very quickly, only for about 5 seconds. They feel the prostate, and it makes you feel as though you want to urinate a bit, because they're pressing on your bladder, because they're pressing on your prostate, which presses up into your bladder. So the doctor says, yeah, everything feels fine. I've not got any concern. It's nice and smooth. Sorry about my phone pinging. Yeah, it's nice and smooth. I haven't got any worries. But what we'll need to do is give you a PSA test. And you get used to that PSA. It's something I'll be saying a lot. PSA stands for prostate syndrome antibodies. Because what the prostate does apparently is that when it swells or when it gets infected with, if it's cancerous cells or whatever, it releases these antibodies into your blood system. And they do this test where they just take some blood out your arm, which is dead easy. Send it away, and within a week they've got the results back, and it's given a number. And now that number that you're allowed to have, because naturally your prostate swells as you get older, that number rises. But the allowance rises with age, because they accept that as you're going to get older, it's going to get bigger, so the number will go up a bit. Anyway, so 2018, I had my bloods. I get a telephone call from the GP surgery saying the doctor needs to see you. We've got the results, and we need to have a face-to-face. And I thought, oh shit. So anyway, I go in, and he says the limit that the NHS advise for your age and whatever is, I think it was 5, a PSA of 5 or 4.5 or something like that. And he says, but yours is showing 7, which I knew, I was having these problems, so I thought, well, it's going to be swollen anyway, more than normal. So I expected it to be a little bit high. And the GP, in fairness, said, well, it's marginal. You're only just above the lower limit. If it was above 10, we would be far more concerned. But yours is only 7. So he says, but you have to be referred under the 14-day cancer screening system. He says, where it's guaranteed that you will be seen within 14 days by a specialist to assess your situation. And in fairness, so he says, I'll do a referral to the consultant urologist at the main hospital, which is in Truro, from where I am, which is nearly it's 36 mile, so it's a 70 odd mile round trip. Yeah, but anyway, it's the main hospital. Truro is the not capital. I'm trying to think of the right word, but it's the main place in Cornwall. Anyway, yeah. So off I go. I go home.
Chili chicken and chips.
And my wife's just talking to me now. Yes, please, love. Yes, please.
What are you talking to?
It's all right. I'm doing a vlog. I'll tell you in a bit.
Oh, well, don't fall into that crap.
Don't fall into that crap.
Please.
Yeah. Anyway, so they sent me home, and basically a few days later, within 4 or 5 days, I think it was very quick, I get a telephone call from the booking office for the hospital, and I've got an appointment with a consultant the following week, which is within the 14 days. So I go and see the consultant, and it's more or less a repeat of what I've done with the GP. she checks me. She does the DRE and says everything's okay, but we'll need to put a camera through your urethra into your bladder to check you all out, make sure everything's looking okay. So I'll stop this bit here because it's 15 minutes. I think that's long enough, and I'll start another one very shortly. So as usual, subscribe, like, and whatever. And as my wife says, don't fall into that rubbish. So, yeah. Anyway, so chat to you again in a bit.